I would like to introduce our first speaker, Dr. Phil Wiley. Dr. Whiley graduated from ANU Medical School in 2018 and also holds a Bachelor of Science in Biochemistry. Phil previously worked at the QIMR Berghofer Medical Research Institute, producing over a dozen publications and coordinating global research efforts in BRCA1 and 2 breast cancers. He's held junior medical positions at the Canberra Hospital before joining the General Surgical Division this year as a registrar. His current research interests include understanding the immune basis and surgical management of Crohn's disease. Please welcome Phil.
Thank you, Ruth. So I'd like to share a case today that was one of the cases through the acute surgical unit, and it hopefully is instructive into helping us manage patients with carcinoid neuroendocrine tumours. So the case involved a 72-year-old male. He had right upper quadrant pain and epigastric pain. At a tertiary hospital, he underwent a CT of his abdomen, and there was multiple right lobe masses in segment 5 of the liver. There was also some capsular deformity, and there was some suggestion of central necrosis in some of those lesions. An ultrasound was done, and there was some gallbladder wall thickening and mobile sludge, but no stones. So the patient had a past history of small bowel carcinoid cancer with metastasis to the liver, diagnosed 4 years before presentation. It was a low-grade NET, and there's his other past medical history there. The blood tests showed some raised inflammatory markers. The liver function was normal, and there was some chronic kidney disease. The patient was on only a few medications. He's otherwise quite well. He was on cholestyramine for bile acid sequestration, and the oncologist also had him using a regular somatostatin analogue. So this is sandostatin. He was using a long-acting formulation monthly, and he'd actually had the last dose about a month before he presented, and he was due quite soon after. His observations were largely stable on admission, and he was initially managed with antibiotics, analgesia. We spoke to the upper GI team here to discuss the options for the patient. On examination, he was very tender in the right upper quadrant. It also said that he was recently kicked by a horse on the right side of the chest, and he was still experiencing some pain associated with that. We gave the surgical options for the patient. We didn't have a clear diagnosis at the time. We thought it was possibly cholecystitis, but difficult to say in the context of the liver lesions. But the patient elected to go ahead for surgery. So a laparoscopic cholecystectomy was done. There was extensive hepatic carcinoid disease, you can see in the top figure. The gallbladder itself looked largely normal. Some inflammation associated with the liver, and some inflammation of the gallbladder, but it didn't look like a clear case of cholecystitis. The gallbladder was removed, and the histopathology came back describing a benign chronic outlet obstruction with some inflammation of unclear sort of origin. And there was one lymph node there which contained a metastatic neuroendocrine tumour. During the procedure, the patient deteriorated quite significantly, developed tachycardia, also wheeze, flushing, sweating, bronchospasm, all the features of a classic carcinoid crisis. And he was given intraoperative octreotide. He developed some ST segment elevation and some clear arrhythmias there. After the procedure, the patient went to the ICU and was stabilised. He did have a significant troponin rise. A bedside echo showed some irregularities with the left ventricle. He was very hypotensive and vasodilated, clearly in cardiogenic shock, and he was given an octreotide infusion at the time. Cardiac angiography overnight showed that there was only minor coronary disease, and it was most likely a Takotsubo cardiomyopathy that was giving rise to the troponins. The next day, the patient made a full recovery. He was virtually asymptomatic, only some post-operative pain, and he was feeling a whole lot better for the surgery. So there's really two considerations out of the case. Firstly, we were never really sure whether we were dealing with some necrotic kind of transformation of his known disease that was mimicking cholecystitis, or whether we were actually dealing with cholecystitis. And the other consideration that could influence practice is how to perioperatively utilize octreotide infusions, especially for these for the neuroendocrine tumor patients. And these can be potentially applied to any surgery. So a little bit about somatostatin analogues. Firstly, we know neuroendocrine tumors, if they're present, can be the basis of a carcinoid crisis. And we do know that manipulation of the tumor, even some biopsies, some radiological procedures and chemotherapy can all trigger carcinoid crisis, but it's well documented that surgery involving manipulation of the tumor can bring on the crisis. So the somatostatin analogues are there to deal with that. They inhibit the inflammation and the serotonin overdrive. So looking at the guidelines, there's American, European and UK guidelines, and they're all different, which always alerts us to the fact that either nothing works or everything works. The American guidelines say that there's no role for octreotide infusion, but they do, however, say that an intraoperative infusion is recommended. The European guidelines say that we should use an infusion before and after and during the surgeries. And the UK have set up a treatment matrix based on the types of procedure and the patient and their control of their carcinoid syndrome. There is one retrospective study that provides some pretty good evidence that using pre, intra and post-operative somatostatin infusions for neuroendocrine tumor patients can certainly prevent the crisis. And I'd just like to thank the team there for their support.
Thanks very much for your presentation, Phil. And whilst it's an uncommon tumour, we are likely to encounter it at some point in time. I just have a couple of questions. First of all, what constitutes a carcinoid crisis, i.e. what are the components of a carcinoid crisis?
Yeah, so it's typically arrhythmia, bronchospasm, and hypotension. And it's really, it is a classic sort of cytokine storm. So you can develop a shock pattern.
And just following on from that, what are the cardiac manifestations of carcinoid heart disease?
Yeah, so the carcinoid syndrome and people with neuroendocrine tumors often develop a fibrotic type of picture in the heart and in the tissue itself. And when the crisis comes on, it can lend itself to arrhythmias, particularly Takotsubo is one clearly well-defined arrhythmia.
All right, thanks very much, Phil, for your presentation. We might move on given we're short on time.